Hey everybody, this is Bob Gibson. I'm an advanced practice educator with Rosk Education. Welcome to a procedure refresher on femoral central line access. Objectives of this session will include indications, complications, and anatomy of femoral line insertion. We'll also explore landmarks and positioning, ultrasound utilization, and the importance of venous line conformation. Indications for femoral line insertion include poor or inadequate peripheral IV access, specific IV medications including extended or high-dose vasoactive therapy, TPN, chemotherapy, or even high-concentration hypertonic saline. Other indications include hemodynamic monitoring, including PA catheter insertion, extracorporeal technologies including ECMO, renal replacement, or MARS therapy. Femoral insertion is also ideal in emergent situations, i.e. ACLS. A provider can be at the head of the bed, managing airway or performing CPR, and the femoral site is accessible for cannulation for a central line insertion. While not exactly an indication, but a benefit of femoral line insertion would be the ability to compress the site under bleeding or coagulopathy circumstances. Complications of femoral line insertion include bleeding, arterial puncture, catheter malpositioning, air embolism, infection, venous thromboembolism, and nerve injury. Let's take a look at infection related to femoral central line insertion. Historical data has showed us femoral line insertion carries an infection risk of 4 to 5 times greater than subclavian central line insertion. This literature was contested in 2012 in a meta-analysis by Dr. Paul Merrick. However, nearly a decade later, IDSA and CDC guidelines have not changed. Current adult guidelines show that femoral site insertion is the least preferred option. Next, let's explore arterial puncture. So this is the inadvertent cannulation of the artery during an attempt at a venous insertion. Literature shows us that a landmark-based approach alone may result in up to a 9.3% risk for inadvertent arterial puncture. We know this can result in major bleeding, including femoral, peritoneal, and retroperineal hematomas. We know that ultrasound assistance can reduce our mechanical complications. In addition, the assurance of guide wire placement in venous structures via dynamic ultrasound imaging may reduce the complication of inadvertent arterial puncture, dilatation, and central line insertion into an artery. Now, what if you do have an inadvertent arterial puncture? If it's just the needle, withdraw the needle, compress, and observe. A standard central line ranges between a 5 to 7 French. If you have an inadvertent insertion of a central line into an artery, keep it in. Consult vascular. As a generalization, vascular surgery would probably discontinue that line at bedside under direct observation of their team. In regards to a large bore central line, this could be defined as a cordis, which is a 9 French, or a hemodialysis, which is a 13 French. If these lines are inadvertently placed into the arteries, keep these in, secure them in place, obtain a stat vascular consult. Most likely these patients will require endovascular repair or open surgical repair. Next, let's take a look at thrombosis. We know that femoral line insertion carries a large degree of risk in the VTE thrombosis category. Up to 25% of patients can have some sort of thrombosis associated with that central line. In one paper that was reviewed, up to 21.5% of patients experienced thrombotic complications. 6% of the overall population had complete thrombosis of the vessel, so essentially DVT. Now let's shift our attention to anatomy. The historic teaching of the mnemonic navel, nerve, artery, vein, empty space ligament, seen here, nerve, artery, vein, empty space ligament, can be confusing, especially when having to mirror that mnemonic to the opposing side. Much simpler is the CVA mnemonic. This would be crotch, vein, artery. CVA, this can be mirrored easily, crotch, vein, artery. Let's take a better look in this slide. To the left, depicting arterial circulation and anatomy, and to the right, depicting venous circulation and anatomy. In the depiction to the left, the external iliacs dive under the inguinal ligament. giving way to the common femoral artery. If you extend more distally or caudally, you'll run into the profunda femoralis. The opposing, the right image over here, you'll see venous anatomy. Similarly, the external iliac vein will dive underneath the inguinal ligament, giving way to the common femoral vein, coming down to the saphenous femoral junction. Let's put this anatomy together and explore some landmarks or site of identification for insertion. Even in times of ultrasound imaging, it's important to identify the femoral triangle. The femoral triangle is outlined by the following anatomy. 1. The inguinal ligament. From the iliac crest to the pubis symphysis, draw an imaginary line. This highlights the border of the inguinal ligament. Next is the adductor longus muscle. And lastly, we have the sartorius muscle. This gives us our femoral triangle of safety. Once we have identified our femoral triangle, it is important to point out that our insertion site should lie beneath it about 1 to 2 centimeters to the inguinal ligament itself. Using an insertion site anything greater than 3 centimeters below the inguinal ligament can increase our risk of complications. We should then come 1 centimeter medially to the femoral arterial pulse. What about in a code ACLS situation? Find the iliac crest, the pubis symphysis, draw an imaginary line. Come to a midpoint of that imaginary line, and now come 1 centimeter medially to that midpoint. Let's apply ultrasound to this thought process. So we come 1 to 2 centimeters caudally to the inguinal ligament, and we would see this on ultrasound. This is commonly referred to as the peanut sign in the ultrasound world. As you can see, we can identify the common femoral artery and the common femoral vein. Now let's inadvertently go too low for an insertion site, and unfortunately we would see this image. This is referred to as Mickey Mouse sign. Here we can identify the common femoral artery, the common femoral vein, but in addition we can identify the saphenous femoral junction. Now let's discuss patient positioning. The majority of our patients can be left in a normal supine position, and we can obtain optimal site conditions. In some circumstances of anatomy abnormalities or body habitus, we might have to take extra measures to ensure safe venous cannulation. This might include leg abduction, externally rotating the leg by about 15 degrees. Some folks advocate for attempting a reverse Trendelenburg position. The thought process is that this engorges the femoral vein. In our morbidly obese population, we may attempt an elevated ipsilateral buttock raise with a pillow or a towel roll. This would expose the femoral site more easily for us. Right-handed operators normally stand at the right side of the patient. Obviously, a right femoral site would be optimal for a right-handed provider. In cases of left femoral cannulation, the right-handed operator can reach over the patient, maintaining sterility. Some may prefer to move to the left side of the patient if they can maintain their dexterity. Let's recap some of our positioning and anatomy. We see this physically fit gentleman to the left. We can easily identify iliac crest and the pubis symphysis. We draw our imaginary lines, and we can see the inguinal ligament. Our depiction to the right here, we can see that the leg is abducted and externally rotate it by about 15 degrees. Now let's focus on ultrasound utilization during femoral line insertion. Interestingly, a meta-analysis showed no differences in inadvertent arterial punctures. It did show improved first attempt success and a small increase in overall success rate. Let's look at the useful information that ultrasound can give us. Looking at the depiction to the left, we can easily identify the common femoral artery and the common femoral vein. This would be our peanut sign. Now let's look at the cine loop to the lower right. This gives us a multitude of components of information that would be useful during essential line insertion. We can identify the common femoral artery. We can identify the common femoral vein. And we can see that our insertion site is probably too low here because we're seeing the saphenous femoral junction. Now let's point out some other issues that we're seeing with this ultrasound that can assist us. The operator right now is doing a compression test. You can see the downward dimpling of the artery right now, but most importantly, in the venous structure, it is not collapsing. This is a large DVT. So to summarize, we're seeing a common femoral artery that's sitting right on top of femoral venous vessel. This is going to make cannulation more difficult. We're seeing a non-compressible common femoral vein indicating a DVT, and we're also starting to see the femoral saphenous junction, which is indicating that we are too low at our attempted insertion site. Further use of ultrasound is the use of dynamic ultrasound imaging to identify the tip of the inserting needle. We're currently viewing a transverse window of a venous vessel. We're identifying the hyperechoic imaging of the tip of the needle penetrating the venous vessel. Here's another example of imaging the hyperechoic effect of the needle tip. In image A, we're viewing in a transverse window. You can see the tip of the needle right smack dab in the venous vessel. In image B, we're viewing a similar occurrence, but this time in a longitudinal view. We're seeing the hyperechoic shadowing of the needle entering midpoint of the vessel. Now let's discuss venous conformation. That is, your central line is in an appropriate position and not in the artery. So we can start off by talking about the blood. Is the blood bright red, thinking arterial, versus dark red, thinking venous? As a generalization, this is a good technique. However, there are exceptions. Brighter venous blood can be seen in the over-oxygenated patient. Darker arterial blood can be seen in the deoxygenated patient or the patient in shock. Next would be the pulsatility of the blood. Pulsatile thinking artery versus non-pulsatile thinking venous. Again, this is a good generalization, but please remember there are exceptions to the rule. We can see folks with pulmonary hypertension, high right atrial pressures, with pulsatile venous flow. And unfortunately, we can also be in the artery in a shock state or a coating situation, and that artery would not be pulsatile. Next, we could actually transduce off the needle of your insertion site. This is cumbersome and time-consuming. The equipment is not always available in the room when you need it. An alternative to this technique, which is more feasible, is what I would refer to as a quasi-manometer technique. Anesthesiologists have been doing this for many years. They take a 10 to 15 centimeter pressure transducer tubing found within their central line kit. They pre-flush it with normal saline. They attach it to their insertion needle, and they hold it 10 to 15 centimeters above the patient's insertion site. Very similar to old school central venous pressure manometer reading, you will expect the venous cannulation to oscillate and hover, not exceeding more than 10 centimeters. If the insertion needle is in an artery, the arterial hydrostatic pressure will exceed the 10 to 15 centimeter distance in that tubing, and it will be seen in a pulsatile fashion, confirming the unfortunate inadvertent arterial cannulation. Next, and probably the best, is using point-of-care ultrasound to confirm a guide wire in a venous structure before you dilate, before you insert a central line. Lastly, venous central line insertion can be confirmed with agitated saline. Let's explore the latter two items in the next set of slides. After a perceived venous cannulation, we can confirm that cannulation by imaging the guide wire within the vessel, prior to dilating the vessel or inserting a central line. In this case, we're viewing an internal jugular venous cannulation, easily identified as the internal jugular vein and the carotid artery. The hyperechoic imaging here is the shadowing seen from the guide wire. This would be referred as a transverse imaging window. More ideally, we'd like to see this in a longitudinal window. This can be obtained by first imaging the venous vessel in a transverse window, then rotating your probe by 90 degrees, and this would give you our longitudinal view that we see currently. Here you can see the hyperechoic imaging of the guide wire within the venous vessel. Lastly, venous cannulation via central line can be confirmed by agitated saline test. 10 mL of agitated saline are inserted within the central line itself, and within 2 to 3 beats of a cardiac cycle, we should see hyperechoic imaging in the right atrium and right ventricle, nothing in the left side of the heart. This is not indicated if you have strong suspicion of inadvertent cannulation and central line placement within an arterial structure. Let's summarize our session. We've reviewed the indications and complications associated with femoral line insertion. We've discussed risk versus benefit. We've reviewed anatomy specific to femoral central line insertion. We've explored ultrasound utilization. And we've taken time to explore venous guide wire conformation prior to dilation and insertion of a central line. Thank you for your attention during this session. If you have any questions or would like additional education material pertaining to this topic, please feel free to email me at learn@rosk-educate.com. Thank you.